Hi, my name is Dr. Bruce Quinn and I'm an expert on Medicare policy for new technology. Today, November 11th, 2021 is a red letter day for precision medicine. Medicare, through its MolDx program, announced it will provide coverage for molecular minimal residual disease testing in both solid cancers and hematopoietic cancers. And the coverage is both for cancer recurrence, such as after colon cancer or breast cancer surgery, as well as for tracking therapeutic response, which means whether the cancer drug is working or not. What's been announced are the principles for coverage. The MolDx program will review individual tests for individual applications on a rolling basis. Let's take a brief look at the new policy. This video is only a summary. I'll provide links to the full text so you can read all the rules and all the details. The policy is revised, but it's still the same basic framework we saw in a draft version in August 2020. This final version was released November 11th, effective in 45 days, and that happens to be Christmas. Here's what's new. Prior LCDs for circulating tumor DNA focused on cancer gene detection, such as an EGFR mutation or an ALK mutation that would lead to a particular type of therapy. This LCD covers both the earliest detection of cancer relapse and also whether a patient's current cancer drug is working or not. Here are the 10 rules that determine coverage. First, if it's an NGS test, and most are, a national policy called NCD 90.2 applies as well. 2, the person has a cancer type that matches the test's indication. 3, NCCN or others use recurrence or progression as a reason to change therapy. I think Rule 3 will always be true. 4, the test detects recurrence before existing tests like imaging, but also about as well as imaging. 5, the test won't be used with other tests that provide the same information. 6, if you are monitoring a particular drug, the test has been validated for that drug type. 7, the clinical validity of the analytes must be published. For example, circulating tumor DNA rising and falling is validated for checkpoint inhibitors. I don't know how MolDx will apply this for sure, but it says the analyte must be published. Not that every single test number 1 and number 2 and number 3, for the same analyte has to be published. So we'll see how that evolves. Moving on, number 8, the patient must match a studied population, which is related to point number 2 and points number 6 and 7. 9, each test must pass a very thorough technical review at MolDx. And finally, 10, the test has to meet a current standard of care. It can't be a lot worse than other currently available tests. It must be equivalent or superior to available tests. That's the overview. MolDx often publishes LCDs with the draft and final nearly the same. This LCD rose from 4,000 words to 8,000 words, and from 40 citations to 89 citations, along with extensive redlining of some of the coverage rules. So far, I think it's pretty clear. We'll all see what happens next. Thanks for watching.